Spontaneous bacterial peritonitis. I find that many students get this confused and they're not exactly sure as to when to choose this as being a diagnosis. Let's first take a look at risk factors for SBP. Recent GI hemorrhage. Ascites fluid less than 1 gram. In other words, there is ascites taking place. Therefore, remember, the peritoneal cavity has not been compromised. There's every possibility that the fluid within the peritoneal cavity may then become infected, and you call this spontaneous bacterial peritonitis. The name pretty much tells you exactly what's going on with these risk factors. And there might be prior episodes of SBP, spontaneous bacterial peritonitis. Microbiologically, the gram-negative organisms will play a role 70% of the time, if not greater. That is extremely concerning. You might have strep and staph, the gram-positive organisms. Oftentimes, though, however, you might find polymicrobial infection, therefore suggesting that the origin of the SBP might have been the bowel that then perforated. How? Well, what if it was diverticular disease, which is extremely common in the U.S.? We have diverticulosis, diverticulitis, and with enough inflammation and rupture, there's every possibility that it might result in spontaneous bacterial peritonitis. Clinical presentation: severe abdominal pain, fever, and perhaps encephalopathy if the issue originated from the liver. Diagnosis: with ascitic fluid in which you would expect, quote-unquote, a peritonitis, you can expect your neutrophils to be quite high. Bedside inoculation of ascitic fluid into blood culture bottles increases your yield. That way, immediately you can tell as to whether or not your patient is suffering from SBP, something that you very much want to keep in mind when the patient is suffering from ascites. Management: third-generation cephalosporin, albumin because the liver might be depressed, and prophylaxis with cotrimetoxazole, sulfamethoxazole, and trimethoprim.